Hi, everyone. Welcome to AMCHP's July 9th all-member National MCH Policy Call / COVID-19 Town Hall. We're just giving folks another minute to sign in. We did have about, I think, 120 or so RSVPs, so I want to make sure folks are on the line before we dive into today's call. But in the meantime, I'm just going to throw up the housekeeping instructions, and as usual, the panelists, but if you're asking any questions for the like during the webinar on the content or of anything that we're discussing, please try to remember to change the chat box piece to all panelists and attendees so that everybody can see the question that you're asking. And I'm just checking, has Jonathan joined us? I believe he was going to try to do a quick welcome. Yes. Jonathan, would you like to say a few words as we get started?
Yeah, thank you, Amy. Again, as usual, thank you to the team for your time and effort in pulling this bi-weekly meeting together. I've really enjoyed the discussions and the opportunity to learn and hear what's happening from you, and also to hear what's happening and what's on the horizon from our federal agency partners at the Maternal and Child Health Bureau and with the CDC. As always, thank you to our membership, the states, jurisdictions, the territories, for all of your hard work and sacrifice in your communities and in your roles and guiding us through these last several weeks. We really appreciate your effort and are very proud to support you as your membership organization in this work. And thank you to our Bureau and CDC partners for your continued engagement in this conversation, and your attention, your leadership, and hearing the feedback from these calls and then responding in kind. So thank you for all of your efforts. I know we have a really packed agenda today with some new contributors to the conversation, our partners from AAP. Thank you for joining, and I'm looking forward to a really robust and informative discussion. So with that, I'll turn it back over to Amy.
Great, thanks so much, Jonathan. Welcome again, everybody, to this week's call. Is it just me, or like these 2 weeks flying by more quickly each time? Today, the agenda, I'll give you a quick legislative update, turn it over to Dr. Warren from MCHB. Our CDC friends don't have an update to give, but we do have some folks from CDC on the call in case there's any questions later on during Q&A. We're glad to be joined by Dr. Nathaniel Beers of AAP to talk about their school reopening guidelines. And then we're also going to talk a little bit about AMCHP's CARES-funded telehealth project, some questions for our members, and to also introduce you to a new member of our team. So on COVID relief, the news, and this is actually from last week, but Senator McConnell had said that the Senate was going to work on their next COVID relief package after the July recess. So now that they're coming back, negotiations are supposedly happening, and there's more and more support that, yes, they are going to work on something, but there's still a lot of hiccups in terms of the priorities from House leadership versus Senate leadership, as we're used to seeing by now. So we'll be keeping an eye closely, but I just wanted to let you know there hasn't been any new legislation passed since the last time we met, but supposedly there should be something in the works before August. And then on the appropriation side, earlier this week, the House Labor, Health, and Human Services Subcommittee on Appropriations marked up their FY21 bill. So this is the regular appropriations, not a COVID relief, although they did have some emergency supplemental appropriations weaved in for CDC. On the HRSA side, there was a $157 million increase overall, including $25 million for the block grant. So we were very pleased to see that. Of course, we won't know the details of how that $25 million is broken down, for instance, between the state formula funding portion or the SPRANS portion until report language is released, and that may not be released until next Thursday when they do a full committee markup. So we'll keep you posted. But regardless, I think a continuing resolution until after the November election is the most likely scenario. The Senate had sort of a false start where they were going to have their markups in June and then postpone them because they were afraid they were going to get too contentious. And now they don't seem to have any plan to work on it anytime soon. So continuing resolutions most likely, which is even another reason why I think a lot of us have been pushing for priorities in the next COVID relief package, making it an even more difficult package to put together. Regardless, AMCHP will be keeping you posted. With that, I will turn it over to Dr. Warren.
Thank you, Amy, and good afternoon, everybody. It is good to be able to join you. I think we are about now 4 months into this response where many of you are still working remotely, and certainly you are focused very heavily on addressing the COVID response, particularly with regards to MCH population. So like Jonathan, I want to thank you for that continued work and working hard to not only keep your communities well, but to keep yourselves well and your families well as part of that process. Happy to give you a brief update from the Bureau, and if we can advance to the next slide. We just finished week 4 of Well Child Wednesdays. So this has been a HRSA social media campaign. You all will remember that a lot of conversation around decreases in well child visits and immunizations after the time where the emergency declaration was made. And so a big push to try to get kids connected back to pediatric primary care providers for both well child visits and immunizations. Every Wednesday for 6 weeks, we've been doing posts on our various social media. Those have been picked up broadly. If you go to the next slide, just wanted to give a shout out to the states that are highlighted in orange. There are 19 of them who have either shared on Facebook or retweeted on Twitter the HRSA messages. The states that are shown in blue, there's still some opportunity for you. So we've got a couple more weeks. And it looks like in particular regions 6 and 8, there's some opportunity. I think if we look at the regional level, some great opportunity. So if you can connect with your departmental social media folks and help us spread the word, that would be great. One of the things we've seen the last few weeks, if you'll go to the next slide, we've seen great participation by our community health centers. Just looking, the height of the bars here corresponds to the number of health centers in states that have been sharing this Well Child Wednesday message. So Kentucky, Tennessee, Pennsylvania, and Ohio leading the pack there. Those health centers are certainly important partners in providing care. And so we appreciate them partnering to get the Well Child Wednesdays message out. Again, a great opportunity for you to do that. We've got a couple weeks left. I did want to give you a heads up. Hopefully you have seen in your inbox, we did a joint letter with CDC's Immunization Services Division. So you hopefully got a communication from Dr. Melinda Wharton and I, thinking about how Title V MCH programs and state immunization programs can work together. Many states are already doing that, but this may be an opportunity to revisit the ways you're partnering, to see if there are ways that you can help. For example, promote the VFC program, help give good information to families about immunizations and the importance of immunizations even during the time of COVID. So the point of that letter was to tell you not only are you free and empowered to collaborate, but you're encouraged to collaborate, and we wanted you to hear that from both federal partners. The other thing I'll give you a heads up on is that in August, HHS is going to be doing a big push around catch-up immunizations. So there will be some additional opportunity for you to share messaging in your states. I'd be curious if you can share in the chat window thoughts that you might have around activities that Title V can do to promote catch-up immunizations. Maybe you've got some things already planned. If not, maybe there are some things that you could think about doing. August is National Immunization Awareness Month, and so the department is going to be really interested in getting that word out about getting kids back to pediatric primary care for immunization. So if you could chat things you might be interested in doing or that you already have planned to do, or if there are things that you need in terms of supports or resources from us, it would be helpful to know that. So if you could chat that, that would be helpful. Just a few more updates to share. So this slide has the modified timeline. You've seen this. Just as a reminder, the block grant applications and reports, as well as the 5-year needs assessment summaries, are due September 15th. Normally, we'd all be scrambling right now. It's July the 9th, and in most years, the block grant application and report is due July 15th. But because of COVID, we were able to extend those deadlines by 2 months. Our team will spend the next 2 weeks after that looking to make sure that you met the basic assurances that are required in the block grant process so that we can release those awards at the beginning of the fiscal year starting in October. And then between October 1st and December 31st, we will be having the block grant reviews. They will all be virtual this year as we head to the end of the year. So on the next slide, we are working to schedule those virtual meetings. So your project officers will be working with you to schedule that. When we have the block grant reviews, the discussion will primarily focus on your needs assessment and the selection of your state MCH priority needs and your action plan that will follow from that, as well as a review of your financial and programmatic forms. And we're hopeful that the shift to the virtual reviews allows more state Title V program staff to participate. When you have those years where you travel to the regional office, I know that you're limited in terms of who you can bring, but this is a great opportunity to pull folks from across Title V into those reviews. If for nothing else than to let them see the process and understand it, but also contribute to the work that's going on in the review. We also are excited that we are going to be pulling in an increased number of family reviewers. That's something that the Bureau has wanted to do for a long time. And there are cost limitations associated with that and traveling more folks to review sites. But with virtual reviews, it actually is a little bit easier to do that. And so the team here is working on recruiting additional family reviewers so that we've got more represented in the review process this year. Next slide. Also, just wanted to remind you about technical assistance. So always we have technical assistance funds available to Title V programs. If you have a request, if you'll submit that through your project officer, this is a great time with your needs assessment and developing your state action plan to be able to think about what your TA needs are. But you may have new TA needs that have popped up as a result of COVID. And so please let your project officer know. And on TA requests that we had already received, we're working with states to make sure that those are adapted to fit a more virtual environment. And so we continue to work with folks who had already submitted those. But just a plug that's money we set aside every year to support states. We're happy to do that, happy to connect you with folks to provide technical assistance. Just let us know your request. And then my last slide, I believe, has to do with SSDI. Just as a reminder, the guidance came out at the end of June. The due date for that submission was extended to September 22nd. And remember that you have the opportunity to submit an abbreviated progress report. So if you've got questions about that, again, let our project officers and staff know, and we can help answer questions that you have. I see there is a question about what's the date range for the virtual block grant reviews. Those will be between October 1st and December 31st. So that last quarter of the calendar year is when those will be scheduled. And your project officers will be reaching out to you to coordinate when those will be held. And I think that is my last slide. We'll advance one more just to be sure. Yep, that's it. All that you're doing. Let us know what questions you have.
Excellent. Thank you, as always, Dr. Warren. And we'll move on to the next presentation, but we will make sure to continue with Q&A at the end. So next, we're going to be joined by Dr. Nathaniel Beers, courtesy of AP, and he's currently the president of HSC Healthcare System in Washington, D.C., and is a general and developmental behavioral pediatrician at Children's National Health System. He has also been the chief of specialized instruction for DC Public Schools and was also the director of the Children's Health Center, which is the largest provider of primary care in DC, Deputy Director of the Community Health Administration and the Title V Director for the DC Health Department. So hopefully you feel at home here among AMCHP members. So without further ado, I'm actually just going to turn it over to you because I think you have a lot of information to share with us today. And Dr. Beers, are you able to?
I'm here.
Here you are. Okay,
Yep.
great.
Great.
Just let me know when to advance your slides.
I will definitely. Thanks for having me. And as Amy said, it is like old home to me to be back together with folks at AMCHP and Title V directors around the country. And so thank you for having me. I am pleased to be able to be with you and make sure that we can share this information from the AAP. I have no disclosures to make. Next slide. Almost 2 weeks ago now, the AAP released its guidance on school reentry. And the AAP put out this guidance because many jurisdictions around the country were starting to come forward with plans to reopen school. And it was not completely clear that schools were necessarily taking into consideration the whole child. And as such, the AAP felt like it was important to put forward some guidelines that encouraged thinking about all the implications of school closure and what the impact was on children. And so our premise is that we are advocating that all policy considerations for the coming school year should start with the goal of having students physically present in school. It doesn't mean that every school in every district is going to be open and have in-person learning all the time, as has been put out in the press. It does mean that that's the place we have to start from, and we need to take into consideration and work together with our public health officials, alongside the education experts, alongside parents and students, as well as pediatricians in the community, to make a plan that is going to address all the needs of kids. And so I'm going to run through some of the sort of general recommendations, but then happy to take questions that may exist. Importantly, we felt like it was important to identify some guiding principles. First, that these policies need to be flexible and nimble. As each and every one of you know, this environment is changing on a daily basis. We get new information, we have new data. We have to be willing to revise and adapt these as we move forward, and acknowledge that different communities are going to make different choices, and it's the right choice for that community, and that we shouldn't be judged based on those decisions that communities are making. They have to be revised and adapted based on the viral transmission level in the school as well as in the communities. They also need to be practical, feasible, and appropriate for the student's developmental age. And that is important, recognizing that the capacity to do virtual learning is very different across different ages, and the capacity to follow some of the recommendations is going to be very different across different ages. There are important special considerations and accommodations that need to be taken into account to recognize the diversity of youth that are being served in schools, including those who are medically fragile, those who live in poverty, individuals with developmental challenges or special healthcare needs or disabilities, with the goal of creating a safe environment for them to return to school. Next slide. In addition, we really should be working hard to make sure that we are working collaboratively so that no child or adolescent is excluded from school unless required to in order to adhere to the local public health mandates or because of unique medical needs, and that we should really working together, all together, to make sure that we're identifying and developing those accommodations that may be needed. And that overall, we should be guided by supporting the overall health and well-being of all children, as I said at the beginning. Next slide. And so what are the guidelines and where are there some differences? So the CDC guidance as it currently exists suggests that the distance between desks or children should be 6 feet when feasible. However, in Lancet on June 1st, the review of many different recommendations was completed, and it does look as though 3 feet may be just as beneficial as 6 feet, particularly if individuals are wearing face coverings. It is incredibly important, however, that we encourage social distancing between adults, and there is evidence that there is a higher degree of a spread between adults rather than from children to adults. And there is a study out of Australia that suggests that in fact, teachers are more likely to get COVID from the teacher's lounge than they are from the classroom. And so thinking through some of those components and really encouraging adults to make sure that they are making good decisions is really important. As far as some grade-specific guidelines relative to physical distancing, we also agree that cohorting classes at younger ages is certainly going to be more feasible to decrease crossover. And so for pre-K and preschool and elementary school, as much cohorting as possible is going to decrease the risk of spread. Certainly as kids are sitting at desks, thinking about the spacing of those desks, as well as at the secondary level, thinking about minimizing or eliminating lockers as high touch areas and areas in hallways that create more traffic strain and stress. And also if schools are contemplating having activities that would increase exhalation, such as singing or exercise or band, that they ensure that there's adequate space between students if they're going to pursue those activities. Next slide. There are also some very specific issues that need to be thought of and addressed, and these just have some very high-level recommendations that were made. There's much more extensive detail in the report itself, but clearly busing is going to be an issue for many school districts, and so taking into account physical distancing, as well as the recommendations for use of face coverings is important in busing, but also thinking about strategies such as assigned seats could be a strategy that could help in the busing space. On the hallway side of things, it's really about reducing traffic in hallways. And so some of that is thinking about how do students spend less time in the hallways. If students are going to spend time in the hallways, are there specific markings to help people be on one side versus another, depending on which traffic they are going? How do you think through those components as a critical portion of planning for the school day? Clearly, there are substantial numbers of kids in this country who are reliant on school meals, and so schools, as they contemplate reentry and reopening, need to make sure that they are contemplating how they are going to safely and effectively deliver school meals. And so thinking about using classrooms, certainly outdoor spaces, is an important part of thinking that through. Outdoor spaces clearly may not be available in some areas of the country, particularly at certain times of the year where it's excessively hot or cold or inclement. And so that has to be a backup plan, but can't be the only plan that schools have. Playgrounds has been a hot topic. It's a hot topic for schools. It's a hot topic for parents right now in the summertime. And so the recommendations that we had are recognizing that physical distancing while outdoors may be very difficult, and that the most effective strategy to reduce risk is actually getting kids outside and thinking about group sizing and cohorting them to make sure that we are helping to manage that risk as we move forward. Next slide. Face coverings. Face coverings should be used as possible based on developmental capacity and feasibility. It is critical that staff are wearing face coverings, particularly if they're going to be within 6 feet of students, and particularly when they are with adults. However, it is important to recognize as well that there is good evidence that face coverings may impact the ability to teach early childhood English language learners and special education students who, when they are unable to see the face and see the mouth, may be not as able to learn the language that they are working on learning. And so alternative strategies such as the clear masks for portions of the day, recognizing that unfortunately those masks do fog up and so are not ideal for full day usage, may be strategies that schools need to adhere to. We do adhere and recommend adherence to the CDC recommendations relative to masking and protective equipment for medical procedures, and continue to think that that is going to be the best strategy going forward. As far as grade-specific issues, certainly, as I noted earlier, pre-K and preschool may be difficult to implement masking. It may be difficult even at some early elementary school ages as kids are touching their mouths and pulling their masks down and touching their noses and all of the things that decrease the efficacy of the mask. And so it is important to take that into consideration as schools are implementing guidelines. Many school districts are contemplating ensuring that kids over 3rd grade are wearing masks, or 3rd grade and up, depending on the school district. But those are the discussions that need to be had based on community health disease burden at this point. On the secondary schools, so for middle and high schools, we are recommending the use of face coverings, particularly if they are unable to maintain the 6 feet distance. Next slide. Clearly, no change in recommending the hand washing. Everybody should be hand washing. Clearly, also making sure that we reduce high touch areas as much as possible. That means if it's possible to leave doors open to classrooms and not inhibit instruction across the school, it is going to be helpful to have fewer people touching those doorknobs all day long. However, it is important to ensure that at least daily cleaning is being conducted on all of those high-touch areas, including high-touch outdoor spaces that are often left out of cleaning plans. So that means railings in and out of the school building. That means if you are going to be using playground equipment that kids are going to be touching, that you should be using, making sure that there's cleaning of that playground equipment as well. Next slide. Screening and testing is a hot topic, and certainly schools are all over the planet on what they are trying to figure out to do in this space. The recommendations that we have is recognizing that temperature and symptom screening at schools may not be feasible in person. Even if only 50% of your students are going to be in person, if you have 1,000 or 500 kids in that school, the thought of screening 250 to 500 kids, and those are small schools because we have many schools that are over that size, would be prohibitive in most situations if you don't want to spend at least half the day doing screening. Regardless, messaging from public health officials, from schools, from pediatricians needs to encourage parents to keep their child or adolescent home if they are sick, and that staff stay home as well if they're sick. We also note that in our guidelines, we do not recommend testing prior to re-entry of the start of school. This will only give a false sense of security to schools that somehow they do or don't have kids with COVID in the building. And in fact, that is only a single point in time. That is not going to give them a good sense over time. And most jurisdictions don't have sufficient testing supplies to do regular enough testing to have that be a valuable asset to most schools. Staff or students with symptoms need to be encouraged to connect with their medical providers to determine if they need testing or not. Next slide. I think one more back, two more rather, and one more, yeah, this one. So what about kids attending school if they're sick? What we can expect, regardless of how open the school is, that many more children are going to be sent home from school when they're sick this year. Schools are likely to require clearance from pediatricians before they return. And there are guidance on what symptoms schools should be looking for. And they are here on the right. And you can expect that these will continue to evolve. They have been mostly stable over the last several weeks, but they did evolve over this spring. And certainly as we see flu season, we can expect that this will get all the more complicated. Next slide. The CDC criteria for returning to school are here. I'm not going to spend a whole lot of time on them. They clearly delineate sort of making sure that kids have periods of time without fever or symptoms before they return to school, and if they've had a known exposure, that they have a period of time away from that exposure before they return to school. Next slide. So what about opening school if you have a COVID positive individual? And so the original recommendations that came out suggested that if there was an individual in a class, that the class would be closed for screening or cleaning rather. If more than one individual in the school was impacted, that the school would be closed for cleaning. And then if you had cases across multiple schools, you would contemplate closing a district. There's clearly a lot more going on in this space right now, and this is a much more dynamic space. And I think many of you are probably working at the state levels to figure out sort of what makes sense in your jurisdictions based on the disease burden. And that will continue to evolve. What we do know is that there is relatively low risk of transmission from child to adult based on family studies. We don't yet have those adult studies or those school-based studies, though more and more data is coming in from other countries, and we continue to monitor that. And that we have strong evidence, as I've shown, that the adult-to-adult transmission in schools is greater than that of children. There's still clearly going to be a need to isolate sick individuals, to perform contact tracing, and making sure that spaces are being cleaned appropriately before they are reopened. And so those guidelines will continue to come out as we move forward over the summer. Next slide. Mental health needs, clearly this has been an amazing strain and stress on families and students, and we can expect that students may well not be ready to learn on day one. This means that they'll have increased levels of anxiety, decreased attention spans. Many of them have had increased traumatic stress, whether that means that they know someone or have family friends or others that they know in their community who've been impacted by COVID, or have been increased exposure to either family violence or personal violence or neglect against them. We know that that is going to show up as children return to the building. To be able to deal with all of those issues, we also need to make sure that the staff is getting the support that they need. They also have been under their own stress of flipping immediately to virtual learning, of supporting students who they couldn't see, of trying to get people to engage in new ways. All of that additional strain beyond just the strain of COVID in their communities means that there needs to be support for them if we expect them to be ready to teach and support the students in their classroom. Next slide. And so what about children with medical complexity? Clearly the need is to do tons of planning today, tomorrow, yesterday, making sure that the team is coming together with the patient and family, the medical team, the school team, to really create an ongoing dialogue. It is not going to be enough to have a one-off conversation and think that that's going to suffice. There are going to need to be complex plans put in place to make sure that the family can make a good decision about whether or not returning to school makes sense for their child. That information plan needs to be developed based on the best current information we have. And as I said earlier, it needs to be flexible and nimble so that we can input new information as needed to ensure that we are prepared to address the changing dynamics. Many of these children will have IEPs or individualized health plans as well. And reviewing these and making determinations about what shifts have occurred during this period of time and what additional shifts need to be made as we recognize the school functionality and workflow will look very different that needs to be put into place relative to this. And remembering that for all kids, but particularly for our kids with medical complexity, the real goal is to work together to reduce risk, recognizing that there's going to be risk whether they come to school or whether they stay home. And so continuing to do that work together is going to be critically important for us going forward. And so I think that was my last slide. And so open to questions as needed.
That was great. Thank you so much. So let's stop for questions here. And of course, if anyone still has questions for Dr. Warren from earlier, please feel free. But I'll start with some of the questions that have come up in the chat box already. The first was, have you heard anything about, about busing? How are we going to support students with the needs for social distancing? Because obviously that greatly reduces the number of children who could be transported at a time.
I'm sure. I think lots of conversations going on with busing. I actually had a conversation about a month ago with a bunch of different transportation experts at the school level to talk with them about what issues they were struggling with. I think the recommendation that we're making is that busing is a problem to be solved after we figure out what's possible in our buildings. But busing shouldn't be the rate limiting factor for school districts. There are other workarounds for us to work through as we sort of think about that in most areas. There certainly are areas that are heavily reliant on busing where if there is not a different strategy put in place around thinking about swing schedules, thinking about multiple routes, thinking about different components of addressing the school day, timing, and other components, that will mean that you can't get all the kids there and also implement complete physical distancing requirements. It is why masking has to be part of the solution because it may well be in some school districts, particularly those with low community spread, that it's going to make sense to ensure that on the bus, everyone wears a mask. regardless of age, and that they put their mask on, and that they have an assigned seat, and you do as much cohorting as possible, and you require that parents do screening prior to getting onto the bus. All of those things could be part of a plan. For many school districts, however, there are other transportation options that may be part of the solution. There may be opportunities to shift the school day for different grades, all of which have to be part of that solution. But busing really shouldn't be the rate limiting factor there.
And of course, I mean, you could probably speak to this much better. Being in a city like DC, where a lot of children rely on public transportation to get to school.
In fact, my daughter asked me that yesterday, which is because the only children who receive busing in DC are actually special education students. And so she was wondering how all of her friends are going to get to high school in the fall. You know, and I think that that is a complex decision that is going to require that we also think about school districts like that and making sure that there are safe biking lanes. There are schools or cities that have shut down streets to increase the ability for pedestrian or biking traffic. All of that has to be part of the plan, recognizing that it also may require dedicated public bus routes for students, even if you don't traditionally have school buses to get students into school.
Thank you. Next question. So the recommendation to limit to the cohort approach. So that's the, you know, is the thinking that if someone is positive but asymptomatic, then at least the spread is more reasonably controlled.
Exactly, right? I mean, I think if you can, if your contact tracing is a smaller number of people who were exposed, the hope is that you have to quarantine or self-isolate fewer people. And so if you can decrease those numbers, it's going to be better for everybody. It's why you hear a lot of conversations about teachers changing classes, not students changing classes. That's rational at the elementary school level. Once you get into most middle or high schools, it's a much harder thing to implement. And so there's some other strategies that you could try, right? So you could do block scheduling, right? So you decrease the number of times a child has a class in any given week. Instead of having every class 5 days a week, maybe you only have class twice a week for 2 hours a day at each time. And so how do you think through some of those components? Many schools already do that type of block scheduling, but it decreases traffic in hallways. It decreases the number of people who are exposed in any given day. All of those components become part of how do you reduce the spread in schools as we move forward.
This is a great question I haven't thought of yet, or and I don't know if anyone's thinking about this yet. What are recommendations related to fire drills and active shooter drills that schools have, and you know, thinking about the frequency of needing to continue to have these drills?
Yeah, Jerry asked this yesterday too. We didn't get to answer it yesterday in the call I was on yesterday, so I'm happy to answer it today, Jerry, which is, I think, this is an area where we need to weigh the benefit versus the harm. And we need to understand and think about what is the benefit we're getting from some of these drills, and whether or not during this period of time of a pandemic, we really should be conducting some of these drills. It will require waivers from reg bodies, both at the state and federal level, to ensure that some local regulations probably as well that I'm less informed on. But certainly it is a really important part of weighing the risks and benefits of how we structure school. This is where I'm sure the benefits are really going to warrant exposing many people in that kind of way to that kind of movement in a building.
And I think it's a good reminder, you know, hopefully we've been talking about if and how Title V programs and other members of ours are being pulled into these discussions in your communities to think about adding to the list of discussions that need to happen. The next question, what funding would be necessary to logistically implement these recommendations? We know there's, you know, teacher shortages, budget shortfalls for basic school supplies. We don't have enough adequate space.
Right. I mean, I think on a good day, schools were already stretched pretty far. We are seeing many jurisdictions that are having incredible budgetary impacts of COVID and have already made plans to reduce workforce or other cuts that are going to make implementation of any school opening challenging. And so the AAP believes strongly that we should be advocating for additional resources if we think that we are going to safely and effectively open schools and keep staff, teachers, students, and their families all safe. It can't be done with the resources that schools currently have. I will say one of the things that I was thinking about coming to this talk today is there's also, I think, as Dr. Warren said, some opportunity to think creatively about some of our Title V funding and how it supports some of our children with special needs in schools and how it might be leveraged to make sure that the right supports and services that really went missing for many kids this spring can really be part of the planning process for schools. And so I hope, right, that you're getting the opportunity to be part of those conversations. If not, certainly the AAP is advocating for that work to happen, and we'll continue to see this as a partnership and happy to work with AMCHP in any way we can to make sure that we help people recognize that this is not going to be a simple task and is really going to require that we figure out how to blend lots of different structures in order to make this possible.
Absolutely. So continuing the discussion about special considerations for medically fragile children, feeling like we're not seeing these populations included in some of the district opening plans that are already being released, like schools saying if a child has a one-to-one or a nurse, they can't attend because of social distancing, feeling like this is exclusion of guidance for this population is causing exclusion in getting back to school.
Yeah, and it's a really complex issue, and it's really highly variable depending on what the medical needs of the child are, right? And so the child who is ventilator dependent or has a trach and is requiring suctioning every 20 minutes and requiring sort of donning and doffing of PPE for the staff who are working with that child every 20 minutes, it's going to be really hard to structure a day that makes sense for that child and keeps that child and the staff and the other students around them safe. And so there are some really individual decisions. It is why, as I said, now is the time to be planning. Now is the time to be practicing some strategies. Now is the time to think about this child who has an immunodeficiency. Do they move ahead of other kids? And so does their class end 5 minutes early so they're not in the hall at the same time as other kids? For that kid who has G-tube feeds, is there a way to space those feeds differently that might allow them to have fewer feeds during the school day so that, again, you reduce the exposures in the building? All of those have to be part of the planning that we do right now. The challenge, as we all know, is that many staff who would do this planning aren't typically there during the summertime. And so it is a hard challenge in front of us that is going to require us to continue to advocate for individuals with disabilities because there is massive amounts of exclusion that happened this spring. And there will only be more as people try and take steps to re-enter and don't think about this. Interestingly, some of the work that I do is with schools that primarily serve medically complex kids, and those schools actually are better prepared than most schools to actually start re-entry. They have all the materials they need, they have the medical equipment they need, they know how to keep themselves and other students safe. And so learning from them and figuring out how those strategies can be implemented at larger schools or inclusive schools is something we have to be willing to do as we move forward.
Right. Yeah, and thinking about the question about children who need aids, I think I was mentioning to y'all on the last call, my kids are both still in preschool, and they actually went back this week, and before there had been discussion about what all the new protocols were so parents would understand, and they had said that if a student needs like a one-on-one aide who's with them the whole day, that would be and again, this is a preschool so it's different, but like that would be permitted because then that person would be part of the cohort, but they couldn't allow kids who would get just like a speech therapist or occupational therapist who comes in, because then that would be changing the makeup of who the bubble is.
Yeah, and it's a hard dynamic, except we also need to sort of, and it is a dynamic that many of our children with special healthcare needs have been struggling with this spring, which is, who do you allow in your house, right? And is that one-on-one nurse who's only working with your child okay? What about that speech therapist who's working with 30 other kids, right? All of those dynamics get hard for these families who are really worried. And one of the things that we have to also force ourselves to do is really think about what the risk is, right? Every medical condition does not inherently mean that you are at higher risk for COVID or complications for COVID, right? And so very early on, everyone said asthma. Okay, well, yes, maybe some very severe asthmatics in kids, but probably not every child with asthma. And so how do we step back and think about that, right? That kid with Prader-Willi, probably if they don't have other complications, is not got other risk factors that would warrant keeping them out of school for a medical reason. Now, there may be behavioral issues. They may be mouthing everything, right? There may be other issues that have to be taken into consideration. But it is a really nuanced issue that is not easily done, just sort of wide swath decision-making.
Thank you. Dr. Warren reminds everybody that you can, that you do have a lot of flexibility with your block grant. So 1/3 is for primary and preventive services, 1/3 for children with special health care needs. So it's a really good opportunity for you to be at the table and think about where you can be able to contribute to addressing some of the challenges that we're discussing today. And there was another question: is there a thought or recommendation around regular routine testing of teachers? So we kind of talked about it for students and how that might be impossible, but is anyone talking about it for teachers? And I think I'd be also curious your thoughts on this. I feel like there's, unfortunately, it seems as if there's this conflict between, looking out for the health of the children versus the health of the teachers. And I'd be interested to hear how AAP is trying to also navigate and bridge that, because we need to be thinking about everyone in this community.
I think so I'll talk about the testing and then sort of the broader sort of teacher question, right? The testing side is the same for a teacher versus a student, right? Which is really, it's going to give us false sense of security, and it's really only a single point of time. And so unless people are symptomatic, wide scale testing of asymptomatic individuals really hasn't been incredibly productive to date. That being said, I think that there certainly are communities where the spread in the community is substantial, that many individuals should get tested because they've had exposure to places or people where there has been a documented spread. And so you look at countries that have been able to contain the virus, and they have moved beyond just, did Amy and Nathaniel sit next to each other? But no, were Amy and Nathaniel in the same room together for a prolonged period of time, at which point Amy should get tested if Nathaniel is positive, right? And so those conversations are conversations that need to be had, and we need to think of testing strategies around that. I think absolutely opening schools doesn't happen without staff and teachers in place. And we have to deal and plan for the mental health of staff. We also need to make plans based on what your staffing is. Some school districts are going to have a greater degree of staff who are older. Some schools are going to have a greater degree of staff who have underlying medical conditions that put them at risk. All of those have to be part of what can we rationally do in our school district, recognizing the disease burden that we have in our community. And so certainly the AAP believes strongly that teachers and staff in schools need the support. We believe that that means additional resources to support them so that they have the masks that they need, that they have gloves if they're going to be doing instruction that involves them touching students, that they have, there was a question about face shields, certainly face shields for staff who are going to be working with populations that may spit at them or be unable to control their secretions as well, or if they're going to be doing diaper changing or other health procedures, certainly making sure that we have that protective equipment to ensure that staff can be safe and that our teachers can be safe. Our teachers cannot be expected to return to school unless they are confident that the schools are going to take care of them and have their best interest at heart. And that is going to require some really hard conversations. It's going to require us to listen to the concerns that teachers have, to make adjustments to our plans based on those concerns, and help teachers understand the data as we understand it today. And inherently, as every teacher who sort of has gone through it this spring and had the successes or failures with virtual learning, they understand the implications of not being in the building better than any of us. And we have to learn and listen to them, and we have to work collaboratively with them. And the AAP has actually been working together with the AFT to think about what our recommendations are and how we implement them collaboratively. We've also been working with the National Association of School Nurses to make sure that we are collaborating with school nurses. But this has to be a collaborative process where we all are working with the primary goal, which is to ensure that we are addressing the health of the whole child. And that includes lots of different factors that have to be put into play and lots of different risks that we have to balance because it is not just the risk of COVID or no COVID. There are a whole host of other issues that children struggle with every single day and that are not equitably impacting our children across the country. And so if we're really honest with ourselves, we also know that in urban areas as well as in rural areas, we have great degrees of inequity around access to virtual learning, but also access to nutrition and mental health services and other health services that each of you work to solve every single day, but that schools are often a big part of a solution for. And we lose them when they're closed.
Thank you. I agree. And I think that's a tension so many of us are feeling right now. And there's so much uncertainty, and there's, I think there's probably many of us who feel like, okay, we can make this work if we need to, but we realize that there's a lot of people in our community who can't. It's not an easy decision, and we're just waiting for decisions like here in Montgomery County, for example.
Yes. Well, and we're waiting for people to be willing to step back some decisions that they already made, right? And so one school district that's really done an amazing job, actually, that should be called out is Denver Public Schools, who initially came out and said that they would like to just do the hybrid model, half the kids in, half the kids out, flipping days, all of that dynamic. And really stepped back and listened to their parents and their staff and the medical community in their area and realized that really they needed to figure out a better way to do it. And so their plan at this point is to return to full-time in-person instruction for all those families who feel like that's the right decision for them, recognizing that some may not make that decision and they have to continue to do some virtual learning there. But that's certainly a process that should be emulated by other people. Other people are going to have to step back. As the disease burden goes up in their communities, we have to expect that there's also going to be a stepping back that occurs, and not be mad about it, and recognize that's going to be part of the process of monitoring the virus and the spread of the virus in our communities.
And we haven't even gotten to the conversation yet about what that means for the employers of the parents, the children, and but we only have 6 more minutes on this call. So, I want to go up. Dawn, you had a question where you said, can you share some examples from these schools for reference? And I'm not sure what these schools refers to. Can you you can take yourself off mute or type in, were you talking about the schools that Dr. Beers was mentioning primarily serve children with medical complexity?
Hi, Amy. Yes, I was. I just thought if there were some specific case examples from those schools that we might be able to share in our advocacy, that might be helpful.
Sure. I think the person that I will refer you to, and I'll make sure that Amy gets her name and contact information, is a woman named Stephanie Porter. She is in Massachusetts and does a ton of work with schools in Massachusetts. and a lot of consultation with schools elsewhere as well in normal processes, but also during this period of time. I will say that here in Washington, D.C., the River Terrace School has been really thinking hard about this process of return to school and thinking about what it means for all of their kids who may have seizures or G-tubes or trachs or ventilators, to figure out sort of what the sort of next steps might be. But I'll make sure that Amy gets that contact information as well.
Thank you, and we will absolutely send that out when we do our follow-up email after the presentation. And then we had some really good suggestions about providing youth and family perspectives as well on school reopening. So maybe we can talk about that. If anyone who's on the call right now would like to volunteer, please reach out to me so we can put you on the agenda. Another issue that has come up in some of the evaluations that we do before and after the calls, where we ask you if there's other topics you want to discuss, is around child welfare and concerns around increase in child abuse. So I just wanted to give everyone a heads up that we are waiting on them to get final approval, but it looks like we will have somebody from ACF joining us from the Children's Bureau on our next call to discuss that topic. So for those of you who have asked to have that included, I don't want you to think we haven't heard you. We're just waiting, they needed to get some clearance to be able to attend. And special thank you to Dr. Warren, who put me in touch with them to invite them to that call. We only have 3 minutes left. So we were originally going to have a little discussion about our telehealth project. I'm going to save that for next time. Did want to quickly introduce you to our new project director for the telehealth project that AMCHP is working on, that was funded through CARES. That's Sabra Ankner. And so you may be hearing from her related to this project, but I'm gonna have this slide and let her introduce herself next time. So we will not be doing these poll questions, and Jess, I'm calling on you to take them out of the slides when we send them back around to everyone. We will also send around the recording of this call, as we always do, and then it gets posted to the AMCHP website. Don't forget to register for our next call, and I hope you'll fill out the survey afterwards. With 2 minutes left, I want to ask Dr. Beers, do you have any final words of advice to share?
Yeah, I would say the other thing, particularly for our Title V directors, that has come up in this crisis has been the need to really help families do disaster preparedness planning. We had a number of families in the DC area. I know of additional families in the Indianapolis area where both parents or guardians became ill with COVID, and there were extreme challenges with placement. Families who thought they had a placement plan in place that fell apart the second that there was a COVID positive individual in the household. We had a number of situations where kids were hospitalized in either acute or subacute facilities for days or weeks on hand because we were unable to find placements for them. And so there is this opportunity to really make sure that families are stepping back as they think about reentry into school and building into that some disaster preparedness training and planning so that they start to really have some of those hard conversations with people who they think will back them up if something happens to them, but need to really get to the core of what's going to be possible, particularly where families have been reliant on grandparents who've been incredibly nervous to take on the care, particularly for those kids with behavioral issues where there may be spitting or biting or things that make people fear that the spread is going to be easier or faster. It is important for us to help our families start thinking about that. And so that's the sort of last piece. And I can't say enough about sort of getting the immunizations back going again. And so thank you, Dr. Warren, for all the work that MCHB and HRSA are doing to help pediatricians get their kids back in their practices so that we can get their immunizations done.
Wonderful. Thank you so much. A bunch of kudos to you in the chat if you haven't seen. This was great and a really important topic. I was afraid I was gonna like dominate with the thousands of questions I have about my own children going back to school. Now I have your email, so look out. But thank you again to everybody who participated today. I know there's some questions we didn't get a chance to get to. We'll get through those. Jess, I'm counting on you to record the chat text for us to go through after and see what we can answer. Thank you. And then hopefully just in the meantime, stay safe and healthy, and we will see you again in 2 weeks. But in the meantime, feel free to reach out to me, to anyone on AMCHP staff, really, if you have any further questions. Have a great rest of your day. Thanks.
Thank you.